Orekwe, but unfortunately she's not able to join us. She had a little challenge today that's putting her in hospital, so she will not be with us today, and therefore Moses and I will be helping her in terms of covering the portions that she was to be covering today, and so today we are going to continue from where we left. We are looking at the final portion of our UTC 2, which is basically evidence-based practices. You remember that we introduced us to evidence-based practices, and she gave us a definition of what it is, and also gave examples of some of the practices that are not evidence-based that we may actually be doing or people do across the world. And therefore, now we want to focus on what are the evidence-based practices. Some of the examples of evidence practices include the CBT, as she mentioned in the last class. We have what we call decisional approaches that most will be covering. Then we have got some family approaches that we shall also be covering. We have the therapeutic community. We have contingency management, and of course, pharmacotherapy for opioid and alcohol dependence. So for today, we're going to cover cognitive behavior therapy, or CBT. We shall also cover motivational approaches, and Moses will do that. And then I will cover the family approaches, some of them. We have quite some content to cover today. So you will notice that we will try and do much more in the group discussion after this session. So CBT, does anybody know what CBT is? And sometimes I say, if you want to remember what some things are, just do it from the known. So cognitive behavior, like the name suggests, combines two things: cognitive therapy and behavior therapy. And that's why it's called cognitive behavior therapy. And that's what this slide is about. For those of us who may be familiar, cognitive therapy is basically a therapy that originated from a psychiatrist by name Aaron Beck, who used to treat clients with depression and discovered that a lot of the things that cause depression are problems in the way they were thinking. In fact, he said that they suffered from what he called cognitive distortions. They tended to distort their thinking. They tended to have faulty ways of thinking, including, errors in logic, or what he called errors of reasoning. And so that is what cognitive therapy is about. You might want to go and read a little more about that. And there's lots of literature by Aaron Beck. The second theory that, or approach that informs CBT is what we call behavior therapy or behavioral therapy. Again, if we remember, behavioral therapy, for those who may be coming from the field of counseling, originated from the works of people like Ivan Pavlov, the famous Russian, who actually did experiments with dogs. And he was not a psychologist. He was actually a physiologist in a way. He was studying the digestive system of dogs to see how fast certain things happen, how much saliva was produced when the dog was digesting foods. But he stumbled on a very important psychological principle, what he called classical conditioning, when he discovered that you could actually train dogs to elicit certain behaviors because of the associations that they made. So the dog began salivating because of just a bell, even before meat was presented. Of course, this gave birth to what was called classical conditioning, the kind of learning that occurs by association. Perhaps you go to school, or a child goes to school the first time, they get a negative experience, and then they begin to associate school with negative experiences, and they begin to be anxious about going to school. This thing is expanded by Skinner. Those of us who have history remember that he studied animals like rats, birds, and he would teach them to perform certain behaviors as a way of showing that you could actually teach even human beings to do anything. What Skinner was trying to demonstrate is that our behavior is learned. It's acquired through the reinforcement we get from the environment. And so he came up with another type of learning. The first one we said by Pavlov was called classical conditioning. Skinner brought what was called operant conditioning, that we operate on our environment. As a result, we face certain consequences. Then we learn that if we want to get good consequences, we operate the environment in a certain way. If we want to avoid certain negative consequences, then we avoid operating the environment in certain ways. And then finally, Albert Bandura, who is actually thought of as a social behaviorist, expanded the thinking of the two, and he came up with what we call social learning. He did lots of experiments, which are called experiments of modeling. He expanded our thinking to realize that sometimes we learn not by necessarily experiencing the consequences ourselves, but by observing experience or other person experience the consequences. And so he came up with another type of learning modeling, all of which fall within the behavioral therapy. So when we think about behavioral therapy, we think of classical conditioning, we think of operant conditioning, and we think of social learning or social cognitive learning by Bandura. So this thinking has influenced, combined with the cognitive therapy, has influenced what we call modern day cognitive behavior therapy. A little bit about cognitive therapy focuses on our thoughts, interpretations as the key things that cause us to feel and behave the way we do. According to cognitive therapy, it is not the events that cause our feeling behavior. It is the way we interpret or think about the situation. And an interesting slide here, it says that the event is not equals to feelings and behavior. So clients will say, I actually took alcohol because I felt angry because my parents denied me an opportunity to do this and the other. And what this theory argues is that an event cannot cause the feelings and the behavior. There is something else in between, which is called the additional position is made up of our thoughts and our interpretation. So before the feelings and behavior, something else very rapidly happens in between the event and the feelings and behavior. That's what we call the thoughts and the interpretations. And therefore, cognitive behavior therapy focuses on understanding these thoughts and interpretations and trying to make a change in this mediational position so that we can then change the feelings and behavior. And sometimes when I want to think about this, I ask myself three things, or I give this example, that someone steps on your toe. If you think that that person deliberately stepped on your toe because they don't like you, you might get angry and slap them. But if you think this person was absent-minded, they didn't even notice, you might just not feel anything. The same event causes different feelings and behaviors. Or you walk out and you say hello to someone and they don't say hello back to you. If you interpret that it's because you're so ugly, nobody likes you, you're going to feel really bad about yourself. But if you think, oh my God, that person is so absent-minded these days, maybe they have lots of problems, you're actually going to be empathetic towards them and not feel as you are going to feel. So what therapy argues or assumes is that the way we feel and the way we behave has not got to do with the events themselves, but to do a lot with the thoughts and interpretations that we give those events. And therefore, focus of behavior now move to behavior therapy, which is the other one that is related to CBT. According to them, this is important. Remember, cognitive therapy, we have said the focus is on the thinking and the interpretations. Now, behavioral therapy, the focus is on learning. The key word here is learning. Remember, we have said behavioral therapy emerged from people who studied learning, classical conditioning, a form of learning that's called associative learning. It came from conditioning of learning where we said people operate on the environment, and based on whether they get rewards or reinforcement, they continue to exhibit certain behaviors. And of course, we said the social learning by Bandura, where you model, and if you see that when someone exhibits a certain behavior, they are reinforced, then you emulate that behavior. So behavioral therapy's focus is on learning, that behaviors are actually learned. And so if we apply behavior, we can teach them new behaviors. That's the focus of behavior therapy. Now, behavioral approaches focus on identifying factors that initiate and maintain behavior. This is important, two keywords here, initiating and sustaining or maintaining the behavior. Behaviorists don't care about history. They don't care too much about what happened in the past. They care about what is it that is sustaining that behavior in the present. So what is it that's making the client to continue using the substance in the present? They focus on both the adaptive and maladaptive behaviors that cause clients problems. And above all, and very important is the last bullet, they focus on what is measurable and observable. So they will not focus on things like unconscious, they will not focus on things like self-esteem, things that you can observe and directly measure. Now that is part of what they're about. Of course, those of you who for psychology understand that we have theories like psychoanalysis and psychodynamic theories which focus on the unconscious, they focus on defense mechanisms. So we are saying this is not the focus of behavioral approaches because those are things you cannot necessarily measure objectively. Now, what does CBT focus on, the cognitive behavior therapy? It focuses on central things. Number one is asking questions. For example, the how question. How can we change the behavior of the client? What skills do we need to do the client? For example, what relapse prevention skills do we need to build in the client? So the what question, we address the things that reinforce or the things that sustain the patterns of thinking and the patterns of behavior that keep the client doing what that person continues to do. The other important thing about CBT is that it teaches clients skills that will help them recognize and learn strategies to do several things. One is to reduce the risk of relapse. Second, to maintain abstinence. This is important. Third is to solve problems. And fourth is to enhance self-efficacy. So you can see that CBT, and particularly the behavioral part of it, is more interested in teaching because it's more of, it believes or it assumes that behaviors are learned. So if you teach new behaviors, if you teach new skills, if you teach new strategies, then the client will change their behavior. Some of the techniques they use include this one, which I like the most, asking questions. Now, asking questions is an interesting thing in therapy and also in day-to-day life. Sometimes when you work with clients and they are distressed about things, you ask them, what is the worst that can happen? And you teach them to ask themselves that, what is the worst that can happen? So in this example given here, this client sees people laughing at them and they become emotionally disturbed. And the client is challenged to think. Supposing you are to think differently, supposing you asked yourself, what if these people are not really laughing at me? What if there are other reasons why they are laughing? What if they are laughing at someone else? It's the same thing with the person who didn't greet you back when you said hello. Instead of thinking that, they really hate me, I'm not good enough, you can ask yourself, what if that person was absent-minded? What if that person didn't hear me? So that is the skill of asking questions. So clients in CBT are taught to ask themselves questions, and this is to explore the relationship between their thinking and how their emotions respond. The other important technique that we use with CBT is to actually help clients to explore the positive and the negative consequences of their behavior. So help them do a sort of analysis. What are the positives? What are the negatives of the behavior that they are choosing? You also teach them to do what is called self-monitoring. For example, if it's about relapse prevention, you help them think about what is it that just happened before the relapse. So by so doing, the client monitors themselves, they monitor their thoughts, they monitor their emotions, they monitor their behavior. You also help them to develop strategies to avoid or cope with high risks. For example, they are in recovery. They were walking home from school or walking home from wherever, and they come across their friend, and their friend begins to ask them to accompany them to see another friend or to a place where they went. How does the client avoid such a high risk situation? How do they do, for example, how do they practice what is called refusal skills? So you can actually teach them that as part of CBT techniques. You can also help them develop effective coping strategies for general life challenges. Now, why general life challenges? Because our clients have learned to cope using the substance with general life challenges. You have a quarrel in the family with a significant other. How did you use to cope? You go and use the substance. Now we are saying we want to teach them different coping strategies. And of course, finally teaching them problem solving. They have not learned how to solve problems over time because probably they would escape from the problems by using the substance. So now it's time to confront the problem, teaching them how to brainstorm possible solutions, teaching them how to look at the pros and cons of those possible solutions and coming up with the best. So those are some of the things that we teach clients in CBT. One of the key hallmarks of CBT is actually homework. This is borrowed from the behavioral approach. Behaviorists love to do homework. Remember, they are teachers. Their method is teaching clients new skills and new ways of doing things. So reading assignments, you give clients to read. You give clients a homework of keeping track, like a diary about their behaviors, about their thoughts. You also help them to practice new skills, something called behavioral rehearsal, because they have difficulty to practice what they have learned they should do. So one of the things you can do with them, whether in a one-on-one counseling or in a group counseling, is to give them a chance to practice. If, for example, it's facing their boss, when they go for an interview, maybe they're going to be going for some interview or for some meeting. Now you ask them to imagine you're the boss and they are the member of staff, and you give them a chance to practice, and then you give them feedback. That can be done in individual counseling. It can also be done in group counseling. The other thing that you want to do, actually, the other thing now that has happened over time is that CBT has been applied in many situations. One of the areas that has been applied is in the therapy that is called cognitive behavior coping skills therapy. So this is a manualized sort of approach, very structured, which applies principles of CBT. It has several sessions, and each of the sessions begins with a discussion of the rationale for the skills that the client is being taught. Then it has got specific guidelines on the skill that they're being taught. A good example is assertiveness skills. Then you have an opportunity to do what we are calling behavioral rehearsal or skill role plays, and of course to practice the particular topic. So it's very structured. You might want to read a little more about it after this. Some of the topics that's covered in this cognitive behavior skills training is how to manage thoughts about using substances, how to solve problems, how to refuse substances, how to plan for emergencies and coping with a lapse, which is common in the recovery process, because we did say recovery is a journey, and we did say addiction is a chronic disease. So lapses are common. So how do clients plan for emergencies? Like the last one, dealing with seemingly irrelevant decisions. Now, seemingly irrelevant decisions is where a client might be doing something totally unrelated to substance use, but eventually they end up using a substance. An example is a client who was in recovery and then for several months, and then they said that one day they went to the supermarket, and this supermarket has two entrances. And on one side of the supermarket, there is a wines and spirits shop. So this day they get into the supermarket to buy toothpaste, and they buy toothpaste, but then they come out on the side of the mall that has got the wines and spirits across the road, and they automatically find themselves going there. So going into the supermarket looks like an irrelevant decision. It's not related to relapse, but you can see the events that follow it end up leading them to a relapse. So we teach clients to look at those irrelevant decisions and see how they are connecting to their relapses or lapses as a way of making them in charge of themselves. So that even when I go to the supermarket, I will alert as to who I see, where I go, what direction of the mall I use. These are all things that we want them to connect to their lapse or to their relapse risks. Now, the other thing we do is history, where we want to look at the link in the chain of events that leads to relapse. Now, many times we think that our clients relapse. It's good to understand that every relapse or lapse situation may be actually related to different sets of events. And when we help our clients understand these sets of events and how they are connected, then they are able to put a halt in good time before the relapse completely happens. It has been argued that before an actual relapse happens, there are three phases. There is the cognitive, there is the emotive, and there is the behavioral. So we want the client to use the actual relapse or lapse behavior level. We can do at the level of emotions or at the level of cognition if they begin to understand the links and they monitor themselves. So helping them to recognize decisions that can be the start of a process of relapse. Now, in terms of efficacy of CBT, there's lots of literature that has been done. There's a lot of research that has been done that supports the effectiveness of CBT of treating SUDs, different types of drugs, including alcohol, marijuana, cocaine, methamphetamine, nicotine, among others. Secondly, it has been found that when CBT is used, clients can maintain the skills that have attained for even a year after the treatment stops. Now, I like Moses's assignment, and I'm going to give one right now. We will begin with West Africa. So this assignment is supposed to be done in groups, but because we won't be able to do it in groups, I will borrow from my guru Moses. So group one is supposed to be characteristics. So West Africa, when we go to the group discussion, please look at the overview of characteristics of CBT. And then we go to the other extreme of the continent, East Africa, look at the primary techniques and applications of CBT. And then we go to Northern Africa, look at the strengths of CBT. And finally, Southern Africa, we were taught by Moreko not to say South Africa, but to say Southern Africa so that we include all the countries of the South. You look at the challenges of CBT. So we will discuss this in our discussion. You will be teaching back home. Please encourage your students or your participants to do these group activities and then present and share with each other. So that's basically what this is all about. And because we will not be having lunch, I will now hand it over to Moses to take you through our second EBP, which is MI. So Moses, please take it up. Thank you.
Let me share my slide. Have you signed out? Yes. I hope you can see my slides now.
Yes.
Okay. So as Beatrice, said, we are going to continue with motivational approaches. There are two main motivational approaches, and they are motivational interviewing, which is MI, in short, and then motivational enhancement therapy, MET. Motivational approaches, what are their characteristics, or how do they view their own modality of operation, is that they believe that change occurs in stages. And motivation for change varies over time. We discussed this, I think it was in module 4. And also, motivation can be enhanced. But it can decrease, and it can also be enhanced. So motivational approaches look at the process of change in this way, that it is not something that is static, but occurs in stages and can go forward or back. Motivational approaches, yes. What are their characteristics? They are client-centered and non-directive. You don't tell the clients what to do, but you allow them, to think about the problem themselves, and you only advise, but you don't direct them on what to do. And they acknowledge that substances have rewarding properties that can disguise hazards and negative long-term effects. We cannot tell clients that there's no benefit in using substances, because if we do that, they will see us as people who are not knowledgeable or who are not truthful. Certainly, there are benefits that they derive from using substances, and that's why they keep taking the substance, because the behavior is reinforcing, is rewarding. So they tend to repeat that behavior. But the truth is that the substances disguise hazards and negative long-term effects. Sometimes they are not consciously aware of what has actually happened to them, except they're in a therapeutic session where you discuss with them and maybe take the history and assess them, and then you bring this, and make them actively engage in thinking about what has happened to them, since they started using substances. That's when sometimes some of them come to the awareness that, oh, so I've gone this far. Sometimes they say, do you know, doctor, I never thought of this. So they help clients resolve ambivalence about treatment and stopping substance use. Ambivalence, yes. Sometimes they may have good, fantastic plans for their future, and but the behavior is not helping them to achieve. And they are dilly-dallying, should I go into treatment or should I not? And during motivational sessions or interviewing, you can help them actually to resolve this ambivalence and to make up their mind towards a positive change. Motivational approaches actually are based on the principles that are, of motivational psychology and also stages of change, which stages of change model, which was developed by James Prochaska and Carlos De Clemente. And they use the internal motivation of clients to evoke and sustain rapid change. What that means is that you don't direct them or you don't impose this change because it will not be sustained. But if you look at their own internal motivations and you are able to evoke it and elicit this, then they will begin to think towards change. And then they'll be able to sustain it because it's coming from there. You only support them and help them and remind them of their own intention, to change and continue with the change talk. Then they are held accountable for what they have said because it's not coming from you, so that they don't turn later and blame you that you are the one who asked them to do so and so. And then they include problem solving or solution focused strategies that build on clients' past successes. Most of them would have succeeded in one task or the other in the past. And we use those past successes, to leverage, we leverage on them and now tell them you have succeeded before. Because of succeeded before, it's not a hopeless situation. You support them, you instill hope in them and let them know that they have what it takes if they are adequately motivated, actually to change and to change their own situation. The counselor in the motivational approaches is not, it serves as a coach. It doesn't really direct, as we said earlier, but it also works on the principle that change is created through the client's will and motivation. It is the client's will and motivation, and not based on the counselor's discovery or interpretation and guidance. No, not at all. You only stimulate that internal motivation in the client. Then it helps the client to discover, to understand, and to build on their past successes. So the counselor only, serves as a coach, but not as a director or the one that will hand directive, do this, do that. No, so that they, it builds a self-esteem and helps them to know that yes, they also have what it takes to be able to, make a change and to live better quality, of life. But what are the primary techniques of motivational approaches? There are techniques, and these are based on frames. We'll get to know what frames, it's all about. It's just an acronym for feedback, responsibility, advice, and then a menu of different approaches, empathy, and then self-efficacy. That's what frames, stand for. We get to know them later in a better way. And then decisional balancing exercises, because you have to take a decision, and then you have the pros and then the cons. What do you do? And identifying discrepancies and then pacing and personal contact with clients that are not in treatment. Let's see what they're all talking about. So, as I said earlier on, frames. Frames simply, stands for feedback. You assess a client, you want to know what the feedback is. And if you have taken the time to assess and be able to establish rapport, and then you give the client a feedback, that helps them actually to begin to think towards change, that you've actually carried out an assessment. It's not just a hearsay, or it's not just an eyeball observation, or it's not just your own opinion, but that you actually carried out an assessment and they're giving them feedback based on that. It helps them. And then the process of change is the responsibility of the client. You're not going to impose it on the client, but you can evoke or elicit this change, from the client, so that they begin to take responsibility and not just depend on you and remain passive in this process of change. Not at all. And then you can advise them. You can advise them on what to do, but you don't direct them on what to do. And then provide different menus so that they have choices to make in which direction to go and what they need, to make such change. And that gives them an opportunity to think through and see which one is best for them. Yeah, sometimes they may ask for advice, then you just advise them, and then they move on with their own support. And then empathy, yes, you have to demonstrate that empathy. You cannot just be aloof, you cannot just be there as a Superman or somebody who is better than them. Not at all. You actually empathize with them. You put yourself in their own situation and see what it feels like, so that you are able to establish that rapport with them, and they are able to work with you. If you don't do that, then you may not seem like somebody who is genuine, or somebody who is not even part of them, or is not really there to support them through this journey of recovery. And then also promotes self-efficacy, helps them to know that they have the resources, they have the internal resources to make a change. They are not just hopeless people, but they can change, for the better. Feedback frames. After assessment of substance use patterns, we said assess the problems and recovery capital. The counselor provides feedback to the client regarding personal risk or impairment. Because we have gone through what recovery capital is all about. So in your assessment, you're looking at many things. The pattern of use and the problems that are associated, are the medical problems, are the social problems, are the occupational problems, are the family or marital problems, are the psychiatric problems or legal problems. What are they? And then the recovery capital. And then the counselor gives a feedback to the client regarding personal risk or impairment. Is it a mild risk? Is it a moderate one? Or is it a severe risk that needs further assessment, and so that the patient can actually go into treatment? So that helps. And responsibility, which is the second letter there, for a change is placed squarely, as I said earlier on, and explicitly on the client. With respect for the client's right to make choices for herself or himself. Do that with respect and let them know that you're not going to provide all the answers. They don't have to depend on you. You are there to support them, but they have the responsibility to make the choices and to move on. Advice. Advice about changing, reducing, or stopping substance use is clearly given to the client by the counselor in a non-judgmental manner. You give your expert, advice, that well, if they seek for it, you give them and say, well, from your own experience and from your own expertise, you think this, if they do this, it will be better. But they have the right to say yes or not to take your advice. So you are just there to advise them, but do it without condemning them, without pontificating. Don't judge them, because in my own environment, most people are quick to judge these people. They stigmatize them, they're stereotyped, and so many other things. So they're quick to judge them as people who are just misfits, in the society. So you don't come with that attitude as a counselor. Menus of self-directed change options and treatment alternatives are offered to the client. Yes, several options, several treatment alternatives, and then the client, deliberates on them and then with that support, he decides which one thing we fit them better. So you give them choices. It's not don't just put them in a straight jacket, but let them have choices. These are the techniques that I use. And the empathy, the counselor shows warmth, shows respect and understanding. When you do that, they see you as one who is actually genuine, and it helps them to actually remain in therapy, to adhere to all the steps they need to take, in therapy, and it helps them, in the journey to recovery. That's why you are there to support them. But if you don't show the empathy, then it's difficult, to carry them along. Self-efficacy. The client develops self-efficacy, is encouraged to change. But that's what we are doing in motivational approaches. You want to change, but change in a positive direction. The counselor helps clients explore strengths and past successes. They have strengths. If you assess them, or you know, definitely they have areas of strength. So you reinforce that and encourage them, and they identify skills and abilities to make the changes. And put it to them. They have the skills. They have the ability to make such changes. And then I promote the idea that change and recovery are possible. That gives them hope. That gives them hope. And because of that, they are able, to continue with the process of a change, and also it motivates them more to continue and to also picture, themselves in the future, that they will be better people. Decisional balance techniques. In life, we have to make decisions at different stages of our lives. There are some major decisions that we have to make, and then sometimes when they are addicted to substances, the judgment becomes very is impaired, and we say addiction is a chronic lasting brain disease, and they tend to lose control of so many things. Their life is just focused towards getting the drug, and then other areas of their lives are neglected. So it's not easy for them to make decisions and good judgment because of the impairment of their judgment. So, but with the counselor, you are able to help them. It's a concept of exploring the pros and cons, or benefits and disadvantages of change. You try to do that with them. And as I said earlier on, some of my patients will say, honestly, I've been doing this for years, but I never thought of all this. I've never sat down to look into all this, but I'm happy now that I can see, and especially when you begin to say, okay, how much do you spend on substances, the time and the amount of money, like on a daily basis, how much is it? Okay, you spend some amount, multiply it by 7, multiply it by 52, and then for how many years, and see how much you are spending on all those substances and then the time. When they calculate, they say, no, I can't believe it. I never knew that I spent so much. And then it helps them to actually want to change, in the positive direction. And then, and the consequences too. Sometimes, they leave their work, their family, and then they spend so much time, in the rehab. And maybe they have lost their promotion and so many other things that have, affected them as a result of their lifestyle. So when they begin to put all these pros and cons, and then they look at it, then they are, motivated to actually change in a positive direction. So, decisional balance exercise. Clearly weighs pros and cons of changing or not changing substance using behavior. The counselor is there to assist by asking the client to talk about both the good and less good aspects of using substances, and write them down in 2 columns on a sheet of paper, so that just suppose them, and what are the good sides, the less good aspects of using substances, so that they will tell you. Like initially, some of them come very psychotic, and then when they are coming back to themselves, and you talk to them, sometimes they can be very defiant, they can be very resistant to treatment. One told me, I don't like what you did to me. I prefer to live in that state of fantasy where I was in the, when I was addicted to the drug. I wasn't living in this real world and I enjoyed it. Now you have brought me to this real world. What are you going to do with me? I don't have a job. I don't have a family. I don't have housing. How am I going to cope with all this? So I don't like this state. I prefer to live where in that psychotic state because I enjoyed it. But with time, we got over it, and then it was something that he thought about it, and then he was motivated to change in a positive direction. So sometimes it happens that way. But when you write them down in 2 columns, then it helps them to look at them and then to connect the two, and it helps to elicit some change in a positive direction. The purpose of decisional balancing is exploring the pros and cons of a substance use problem. I used to tip the scales toward a decision for positive change. When you do that, you actually help them to tip, the decision for change in a positive direction. And most times, they want to change in a positive direction and not in a negative direction. So, identifying discrepancies. Help clients recognize discrepancy or gap between the future goals and current behavior. You want to be a successful, maybe engineer, a doctor, or whatever it might be, but you are not studying, you are using substances, and then you have dropped out of school, but you see, nurture that dream of becoming a successful person in life. So how are you going to do it? How is this current behavior going to help you to be a successful person in life? So you have to do that. Then it sets them, thinking, and then they can now see the discrepancy. For instance, how does your cocaine use fit in with having a happy family and a stable job when all your time is devoted towards taking cocaine, and cocaine takes all your money? So where will be the money for the family? Where will be the time for the family? And then how will you even be able to secure a job and maintain it? So these are things that you help them. And it's actually this process of discrepancy that moves them to change. Because if there's not one that discrepancy, then it helps them to take action, either in the positive direction or in the negative direction. When clients see present actions conflicting with important personal goals, change is more likely to occur. That is the time that change, they begin to think about change, because that behavior is not going to help them to realize their ambition in life. Pacing. Each client moves through stages of change at his or her own pace. You don't rush them, because some people can make up their minds very fast, some recover very fast. And it depends on their personality, it depends on their genetic makeup, it depends on the kind of substance they have used and how long they have used the substance and whether there are co-occurring disorders or not. So some people will be very slow. In fact, when you engage them and you ask simple questions, they say, "Oh, please give me time, let me think about it." And they stay there for a while before they move on. You have to be patient enough to allow them. You don't rush them, because they can become discouraged. They don't think fast. And sometimes they tell you that, honestly speaking, my thinking process is very slow. I'm not as sharp as I used to be. Of course, you understand with them. So pushing a client, it consider meets client at the stage in which he or she is. Meet them just at that point. Don't be ahead of them, don't be behind them. Just meet them where they are and then move along with them. They'll be able to establish a rapport, and they can rely, and trust you to help them or to support them through the process of change. And then pushing a client at a faster pace that he or she is ready to take may cause the relationship between counselor and client to break down. And for inexperienced counselors, that's happened. In my center, sometimes we find that the client is not actually making progress. And as BT will always say, is it that the client has failed, or is the therapist that has failed, or the system has failed the client? And most times, truly speaking, it is just that with an inexperience, or we don't really have the techniques to help them change. So we've had to assign, different therapy to some other clients, and then they are happy with it. Sometimes they come complaining, "I don't like this therapist. Can you help me change?" I say, "Okay, no problem." So, and then personal contact with clients, not in treatment. Research shows simple motivation enhancing interventions like letters and telephone calls encourage clients to, one, return for another clinical consultation. They might have missed it, or not even willing to engage in treatment anymore. But just that simple phone call makes them feel valued. Oh, he still cares about me. he still remembers me. And then they get talking. Sometimes we meet them at a crisis point, and that phone call can be like a savior, really. And return to treatment following a missed appointment or stay involved in treatment and increase treatment adherence. Oftentimes, you find our clients who are in recovery, sometimes they meet with some difficult situation or at home, or they're having conflict with family member or the parent. In fact, they can call you even, at midnight and start, in my environment, it's a very funny one. They can call you at midnight and start reporting their parents, to you about what they did to them that they're not happy about. But because of the kind of environment and we live, we understand with them and allow them to call whenever they're in crisis. They call either their case managers or maybe one of their counselors that they trust, and then they discuss and we give them the time because we know that we need to support them. And if they're making effort, we need to. And that actually helps. The several clients we say, do you know that just this thing alone that you did to me makes me feel valued at home? My parents, treat me like an outcast. They don't value me. They have used all kinds of derogatory words, on me, and I don't even seem to have any respect, with them. But your phone call sometimes when you talk to me, it makes me feel valued. I recall an experience. A client visited me with his father. They were traveling from one city to the other, and then they stopped by. He's in recovery, and they stopped by to see me in the office and just to say hello. So they came with the father, and when they came and visited me, it was on the weekend, on Saturday. I actually saw them off right to the gate of I shook his hands and then I left. So he called me later. I said, Dr. Moses, do you know what? My father could not believe that you gave me that attention, that you could see me in spite of your status, that you could see me off to the gate, and you shook my hands. And he felt, no, that he wasn't really doing the right thing, that I value him and I have respect for him, that actually changed his father's attitude, towards it. And he was actually very grateful to me. He had dropped out of school, but I can tell you he eventually went back to university, completed his studies. He's doing very well, and he called me some time ago, told me he's preparing, for his wedding. Such things happen. Then motivational interview definition. Counseling technique or style focusing on creating a favorable climate for change in a person-centered setting. The environment must be favorable. If it's not a favorable climate, they are not disposed to change. So you must work as a therapist, use your skills to create a favorable climate where change can take place. And the essence is collaborative in nature. Communicating in a partner-like relationship, not a master-servant, or begin to put unnecessary hierarchy, between you and the client. It doesn't really help them. And then interviewer create a positive interpersonal atmosphere. It takes skills, for you to be able to do that. But we learn, as we do the work. And what are the principles of motivational interview? 5 primary principles or concepts to enhance the client-counselor relationship as summarized by the acronym READS. First one is role with resistance. If the patient is resisting a particular topic, he doesn't want to talk about a particular issue, you don't keep stressing that he must talk about it, and then you get stagnated at that point. No, you must have the technique to roll with it. Express empathy with them. Don't judge them. Try to put yourself in their own situation and see, where they're coming from. See things from their own perspective too. Avoid argument. If you argue with them, they're likely to shut up, and they may not even trust you, and they may not want to continue. And in fact, the motivation may even diminish. And then develop discrepancy. Always try to develop discrepancy between their goals and their lifestyle. It's the discrepancy actually that moves them to change. When they see that discrepancy, it motivates them, towards change in a positive direction. And then do your best to support self-efficacy. Don't direct them on what to do. Let it come from them. They have what it takes. They have the resources to change. Counselor uses 4 basic therapeutic skills or methods: listening reflectively or responding to a client statement by stating back either the essence or a specific aspect of what was said. This helps the patient or the client to know that truly you are paying attention, and you have to be an active listener, because it's only when you reflect it back to the client and then, okay, I'm really understood now, and he's actually paying attention. Then he cannot really engage in the therapy. And they're asking open-ended questions. Don't put them in a in a closed box. Ask open-ended questions. Allow them to think and to move either way. That actually helps. Don't make them have either yes, ask questions that will have either yes or no answer. No, learn to ask open-ended questions and affirm them when they have done something goes great, well done, you are doing very well. I'm really impressed by your enthusiasm and by the way you are really thinking, and you are really very intelligent. I think you can do much more than that. When you do that, it helps them. In therapeutic community, one of the principles is this: affirming. You affirm them, and that really helps them to, and it's reinforcing, and they want to actually repeat that behavior again. So affirmation is good not only for clients, for all of us really. And then try to summarize what you have done with the client so that you don't lose, so that you don't forget. Because you can summarize, and then next time you know where you're heading to. So responsibility for change is left to client, in that the goal is to increase intrinsic motivation to make the change, and then change is never imposed. MI and SUD treatment, first used to improve adherence to treatment, can be assessment strategy and can also be therapeutic intervention. During assessment, the client may not be willing, may be defiant, may be resistant, but if you use your motivational strategy, you are able to help him to go to the assessment, and also you can use it as a therapeutic intervention too. And they explore and resolve ambivalence and resistance and apply specific skills and strategies to create a climate for change based on the level of readiness of the client. So motivational enhancement therapy is another one that research has shown that has been very effective. You help clients create their own motivation for change, consolidate on client decision and plan for change. It is their own decision, so you consider on that and help them. The approach is client-centered. Remember, it's not from you, but counseling sessions are planned and directed by the counselor. And met and goal setting. Counselors impose no absolute goal, not at all. Let it come from them. You only help them to plan and plan together with them. And counselors may advise, as I said earlier on, about specific goals such as complete abstinence. There are times that they say, no, I don't, okay, I can cut down. But you tell them that at this level of use, it's a severe one, and if you want to cut down, it may not work. I think if you strive for abstinence, it will be better. So sometimes you need to guide them. A broader range of life goals may be explored, not only talking about the drug use, but we also talk about maybe job and then other family issues, maybe reconciliation with family members. And main concept of ACD problems. The ACD problems are viewed as behaviors at least partially under voluntary control of the client. That the client, you don't see the client, somebody who has totally lost control, but that, of course, there's some voluntary control. And then normal principles of behavior change apply when you're doing motivational enhancement therapy. So what is the summary here? Based on principles of cognitive and social psychology, where the counselor assumes that internal motivation is a necessary and often the only factor needed to create change, not an external motivation. You help the clients perceive discrepancies between current behavior and personal goals, and that motivates them to change in a positive direction. And then you emphasize clients' self-motivational statements of both desire for and commitment to change. Keep taking them back to their statement, self-motivational statement. So you remind them that it's coming from them so that they be committed, and then you can hold them accountable for what they have said. Effectiveness, yes, researchers have found that MET is effective when you use for people who use alcohol, marijuana, and then nicotine. So we end here with motivational approaches with group exercises. Those 4 groups that Beatrice, has given assignment, they still stand. So I will go in our own direction. Group 1, please look at the primary techniques and applications of this motivational approaches. That is for West Africa. And then group 2, the challenges will be for East Africa. And group 3, overview of characteristics will be for North Africa. And group 4, the strengths will be for Southern Africa. So let me take you to the, I take you back to the resource page where you can do it. So I'm trying to take you back to the resource page so that you can now check it and use it for your own assignments. So I will just show you, then Beatrice will continue from there. So the resource page page 7.3 is here. So you will use this. I hope you can see the resource page. You can use that to help you with your notes and your journals and then your manual. And this resource page that will be able to help you to complete the assignment. Please do them, and we can continue, on the email. Thank you very much for your attention.
Moses, before we let Beatrice answer the next question,
Pardon?
Before we move it on to Beatrice, you do have a question that probably we should answer, which is about using motivational techniques for people with opioid use disorder.
Do you use motivational what? Sorry, please.
I'm sorry, motivational technique.
Yes.
For people with opioid use disorder, because you listed alcohol, yes, marijuana, and tobacco.
Motivational techniques, in fact, they can use they're more effective for we say alcohol, marijuana, and nicotine. But in dealing with addiction, you use the motivational techniques right from the assessment, and even when you are detoxifying them, and then it helps. It may not be as effective in those who are dependent on opioids, like those who are dependent on alcohol, whatever, but it actually helps them to, for instance, to come, they may not even like the assessment, and they keep dilly-dallying, okay, well, I'll make up my mind. But when you now use your motivational techniques, they may say, okay, I'm coming next week. And truly, most of them, when they give me time, they keep to the time and come, because I'll be able to motivate them to see the reason why they should come. And then the same thing, continues, even when they are taking the drug. As a motivator, it gets to a point that after, even those of them who might even be on substitution therapy say, I'm tired. I think I have what it takes to remain abstinent. I don't need any substitution therapy. I think I can go in alone. And some of them have succeeded. So motivational interview is good for every addiction, but it works better for some than other substances. I hope I have answered the question. I'm not sure.
Yes, I think so.
Any other questions, please? So Beatrice can go ahead if there's another question. Or if you chat, I can respond on the chat.
Thank you, Moses. Thank you. I got some feedback that I had a bit of echo, so I'm trying to see whether using earphones makes it better. So feel free to send a message on chat. I always struggle to use earphones, but I have to because it is trying something else. So Moses has taken us through motivational interviewing. Earlier on, we covered CBT. Now we want to look at family approaches. Before we look at family approaches, I want to pose a question to you for your reflection and for your journal. Do you think we should involve families in our work with clients? Or do you think involving families is a liability? So this is like a debate. Should we involve families or should we not involve families? What are your thoughts? Can people from now, West and South, give us the advantages of involving families? And people from North and East, give us the disadvantages of involving families. So Western and Southern Africa, advantages of involving families. Eastern and Northern Africa, the disadvantages. Yes, Fatima Abiola, please unmute yourself.
Well, I think involving family in the client's issue is very important. Like we discussed in the past module, we said family is part of recovery capital. So, and also family plays a very important role in the recovery of the client. if the family cannot accept the client, then the society will not accept the client. So family is very important. One, family is the recovery capital. Two, family is the one that will first support the client, because they are the ones that will be hit if the client did not change. Thank you.
Thank you. That is Western Africa. Thank you. So that represents West and South. So now, East and North, give us the disadvantages of involving families in therapy. Yes, disadvantage. Now, we are in a debate. So West and South have said we should involve families because they are a recovery capital. Now we want to hear North and East telling us why we should not, or the disadvantages of involving families. I'm sure sometimes you have seen families involved and it's gone crazy on your treatment intervention. So 2 participants have raised their hand. I am not able to tell their names, so you could unmute them, Kim, and one of them can speak.
Yes, Eugene has his hand up.
Okay, Eugene?
Yes, but I'm in West Africa, and I've
I want, so I want, you see,
okay,
now
so
I want to hear.
About disadvantage, if you don't mind.
Yeah, yes, give a disadvantage.
Yeah, I think that I admit that addiction is a family disease, all right. But the challenge is that as we learned the various roles of the family member in enabling and other things, if we are not able to identify the various roles played by family members that kind of promotes the addiction, then we run a risk of involving this same family in therapy when the family itself is dysfunctional and needs treatment. So when the family itself needs treatment, then it becomes a disadvantage in involving them at the early stages of therapy, as it will kind of worsen the person's condition, and the family are more prepared to throw away your therapy and want to move on because you are making the family look bad when in fact you are.
Thank you, Eugene, for those very nice sentiments as well, and thank you, Fatima, for your sentiments. Indeed, we will continue with this discussion on the chat. And what I want you to think is that while family is very important and we need to involve families in SUD treatment, we also must ask ourselves whether the family is actually positive or negative recovery capital. Remember, Morekwe told us that sometimes the very same recovery capital we talked about can actually be negative recovery capital. So we need to ask ourselves, how are we going to make sure we involve the family, but ensure that this family is recovery capital? So some of the approaches we are going to discuss under family will give us an idea of some of the things that we can possibly do as we work with families. So as we begin this section, I wish to note that we are not necessarily becoming family therapists. What we are doing is getting exposed to some of the things we can do to involve families in treatment. So there's a difference between family involvement and family therapy. So what we hope to take from here is more of family involvement. And that's what this slide is saying, that family involvement is not a model, but it can actually enhance outcomes. And we are acknowledging that many of our programs that do offer some family services at whatever level. And of course, if, like I have mentioned before, we have an entire curriculum on family in advanced UTC. And if you're interested, I'm sure that is something we can work on learning along the way because it's very important. So what we have here is basically introductory, information about family involvement. Indeed, family involvement is important, and there are many things you can do with families when you involve them. One, you can do family education, or what we call psychoeducation, where you teach family some of the topics like the ones we mentioned in the last class that we also teach our clients. For example, you can teach clients about the model of disease of addiction. You can teach families about relapse, amongst other topics you can teach them. The other thing you can do with families is that you can have what is called family support groups, where you put families together. Yesterday, we heard about from Moses, Al-Anon, for example, is actually an example of a family support group. So you can actually bring in families to start family support groups. You can also bring in families for counseling, where you actually give them an opportunity to share, whether it's at an individual level or at a group level, where they share their own feelings and concerns and experiences around the work with their clients or living with a family member with substance abuse. So of course, this slide is talking about why we should involve families. And some of the families of our clients, like Eugene has acknowledged, have very many challenges. Some exhibit inconsistency in behavior. Some have got few or rigid rules. Others have got many rules that are not necessarily flexible. Others have emotional distress. And even others have medical issues in response to stress. There's a program I like watching on TV, and the mother in that family, who is the key character, all the time when her children have a problem, she sits down and swallows some pills. Every time when she hears another of her children has some drama, she asks, where are my pills? And I keep wondering, what are these pills that she keeps on swallowing? A lot of our family members who have clients with SUD are actually using medication as a way of responding to stress related to our clients. So we need to involve them because we need to bring them on board to address some of those issues. And so in this slide, we are saying that family members need to be involved with the client. Remember, we need to remember that family members are the ones who are involved with your client before they came into treatment, and they will also be the ones that will take up your client after treatment. That then means that we have an obligation to invest ourselves in the family functioning. Because if we can be able to work on the family, then we can have a positive influence on our client's recovery, because then our family or that family can become a positive recovery capital, away from being a negative recovery capital. Now, what is it about family involvement we can do? One, they can learn about SUD as a chronic disease. This is important because they'll be able to understand how is SUD intertwined with their very many family problems. Sometimes it's family conflict. Sometimes it is other family members beginning to use substances. Remember when we talked about the codependency roles, when we talked about some members becoming, scapegoats, where we talked about some members becoming or behaving like mascots, when we talked about some members being enablers. So when you bring in families, you can educate them on some of these things. You can also help them to learn how SUD causes and affects the family from the different family perspectives that we talk about, the family as a system. You can also help them look at how family relationship patterns work against recovery. I shared with you that one of the things I have seen with clients is clients, particularly heads of the family, who come from treatment and they come home and they have recovered and they now want to be engaged with the family because it's part of what you have taught them in recovery. But then the family doesn't know how to relate with the new person that has recovered because they were used to living without that person. And that can actually work against recovery. So we did talk about the need to shift the family roles, the need to start realigning the family hierarchy as a way of improving our recovery of our clients. So that's an important goal in involving the family. Also, we involve the family because we want to prepare for early recovery challenges. Remember, as your client goes through early stages of recovery, the issues of the risk of relapse are high. Remember, your client is with family. It is family that can actually recognize some of the early signs of relapse or relapse risk. And therefore, when we actually bring them for part of our intervention, and we teach them some of this knowledge, or we give them some of this knowledge, or we psychoeducate them on some of this, then they are better able to support our clients during recovery. They are better able to recognize when the client is at risk of recovery and of relapse, and they are better able to even make an intervention to prevent a lapse or even a lapse from turning into a full-blown relapse. The other important thing that makes us bring families on board is to help them discover and build on their family strengths. Remember, we said families have great strength. Sometimes the strengths in the family is the ability to be resilient and readjust to the different changing circumstances of the family. We also need to help the members themselves find long-term support for themselves. That is important. Let us keep in mind that families can also be negative recovery capital, or what we are calling roadblocks to recovery. And therefore, by bringing them on board, we want to turn them from a roadblock to a resource. And why we do this is because we recognize, like I said earlier, many clients come from families that are chaotic and dysfunctional. And sometimes it is that chaos and dysfunction that actually contributed to the coming up of the SUD in the client. Other times, our families have what we call multi-generational problems, whether it is SUD problems, whether it's mental disorders or other dysfunctional problems. For example, from the biological perspective, we know that mental disorders can run in families. We also know that SUD can have genetic predispositions. So sometimes you may find our own clients are coming from families that have got all these many generations of substance use disorders, or all these generations of mental disorders, amongst other things, or relationship difficulties and conflicts. So by bringing the family on board into our treatment programs, we are able to make them aware of all that and how that can work against the recovery of the client. Now, we have several approaches that are evidence-based, and they are based on the family model. We have got what we call BCT, or behavioral couples therapy. We have got what is called MST, or multi-systemic therapy, used for adolescents. In fact, the last three are used for adolescents mainly, adolescents with behavioral problems. We have the multi-dimensional family therapy, or MDFT, for adolescents. And finally, we have what is called the brief strategic family therapy, or BSFT, for adolescents. Now, what I want to observe about the first one is that it is based, just like the name suggests, it uses a behavioral approach on couples, or it borrows from behavioral therapy and is applied on couples. Then the second and third actually borrow from the system theory, whereby they believe that our client does not exist in isolation, but exists in a bigger framework, in a bigger system. That system could be the family, the system could be the school, the system could be the peers, the system could be the neighborhood. So what you will see in the second and the third is that they basically are very intense. They go beyond the client into the family, sometimes into the community. Sometimes they live and see clients who are not just in their homes, in places like the court. They will see them within the community. They will see them at school. They're very, very intense methods. Now, the final one is borrowed from the strategic family therapy. Strategic family therapy basically talks about clients' problems being because of dysfunctional strategies of family interaction. And so, according to them, and it's called brief because it focuses on the problem itself without wanting to look at where did the problem come from. You look at the family, see how they're interacting, look at the strategies they're using, and ask yourself or ask the family, are they functional? Are they giving you what you want? If they are not, what would you like to change about those strategies? So that's basically, in summary, what this is about. We'll just run through each of them briefly, and then you can always read a bit more about them later. So the BCT, or behavioral couples therapy, like I have said, it's anchored on the strength that a couple in itself can actually be a resource that you can use to reinforce abstinence. So according to them, remember they're coming from a behavioral perspective. Remember we said behaviorists believe that our behavior is shaped by the reinforcers or rewards we get in our environment by behaving. So according to this theory, the intimate partners can be a strong reinforcer to support the behavior we want, that is abstinence. And so this therapy focuses on helping the couple to reduce stress in their relationship, because the belief is that stress in the relationship is a big factor in bringing relapse. So some of the components of this program include making the couple design what's called a recovery contract of abstinence. You give them assignments and activities that will enhance their relationship. And then, of course, you teach them about relapse prevention. It is a very structured method. It can run between 15 to 20 sessions, which run over 5 to 6 months. And you can see some of the things they do in the session. You assess how the couple has been since the last session. You look at the level of compliance to the recovery contract that they signed. You look at homework assignments and how they are being done. You discuss any relationship problems and present any new materials. And of course, you give them new homework. So the essence is that the intimate partner supports the client in the recovery process by reinforcing behaviors that are related to abstinence. And it has been proved to be effective in working with men who had alcohol use disorders and their spouses, as well as men and women with drug use disorders and their significant others. When it's compared to individual therapy or treatment that was done, it was found that 1 year later, those who had undergone BCT were actually doing better in terms of attending treatments, adhering to naltrexone for opioids, and even in terms of absent. And there were less problems, whether family or legal, among these people. So it's an interesting therapy. You might want to go and read a little more about it. It has very interesting concepts. For example, it talks about the couple giving little gifts to each other, having a day where they give reinforcement to each other. So you can look at it and understand a little more and see ideas you can actually borrow and enrich your family involvement programs. Now, the second one, like we said, is the multi-systemic therapy. Just like the name suggests, it looks at therapy from the perspective of the system rather than the individual. It is intensive and it can be done at home as well as within the community. Like we said, it's a therapy that's done for adolescents with SUDs, and it targets changing the behavior, not only of the adolescents, but also the parents. And it uses strategies from CBT and other social development strategies. And of course, it does concentrate on family strength. I like to emphasize the issue of family strength, just like the other day we talked about strength-based approach in this curriculum, because while the client may have many problems and the family may have many problems, they may still have lots of strengths. Maybe the strength is the concern they have for each other. Maybe that's what you want to tap into. Maybe the strength is the commitment they have for each other. These are some of the things you can tap into and help them change them and use them to support recovery as opposed to sabotaging recovery. We have said that the interventions occur in home. Why at home? To overcome the high dropout rates. Remember, these are techniques which are being focused on adolescents who have difficulties with school, difficulties with following the law. So one of the advantages is that you go to the homes of these adolescents as a way of ensuring they stay in the program. So it promotes responsible behavior and reduces irresponsible actions by family members. And it also addresses the current issues in the client's life and targets looking at the immediate actions to address the immediate problems that are affecting the client. Now, it focuses on assessing patterns of behavior within and between the elements in the adolescent's life. Now, this is important, within and between. So if it is within the family, they look at the patterns of behavior that are affecting or sustaining the client's problems. If it is between, they look at what is the relationship between the client and the school, the client and the teachers, the client and the friends. What about the client and the neighborhood? The idea is you want to strengthen the patterns of behavior so that they are behaviors that stop sustaining the substance use behavior or any other negative behavior, but instead you want them to be relationships and interactions that strengthen the desired behavior. And of course, they focus a lot on peer relationships, as well as bringing back the adolescent to some normal life, whether it is academic or vocational skilling. Now, it's important to note that just like the earlier theories we have said, MST does not focus on gaining insights into the past. There are some theories of counseling, like psychodynamic oriented theories, whose focus is on going into the history of the client to know what happened in the client's past, to be able to use it to determine or to explain what is happening in the client. This theory does not do that, or this approach does not do that. At the same time, it doesn't focus on blaming or labeling the parents or the family for the problems of the client. Instead, it looks at how it can empower the caregivers to become long-term recovery support for the clients. And interestingly, this approach holds the counselor responsible largely for the treatment success of the client. Now, it has also been found to be effective significantly in reducing adolescent drug use during and for at least 6 months after treatment. These are some of the indicators of success of this theory. And it has also been shown to reduce the number of incarcerations and what we are calling out of home juvenile placement. So an interesting approach, which is useful for adolescents. The third one is what we are calling multidimensional family therapy for adolescents again. Now, it is probably an extension of the multisystemic therapy, but with a bigger focus on even the greater society, the bigger society. So this one assumes that the client's substance use is not necessarily an individual problem. It's not even just linked to the family, but it is also linked to the greater society network. And therefore, it focuses on addressing the different dimensions of the adolescent's life, whether it's the individual, the family, the peer, and the community. They hold the sessions in the client's homes, just like the multi-systemic therapy, but in addition, they could actually go to a lot of other diverse places, like the school, like the courts, or even in the community. Now, the counselor and adolescents collaboratively work on several things. For example, they may focus on developmental tasks. Developmental tasks is what is expected of a person as they develop across the different stages of development. They focus on decision-making, issues of negotiation and problem solving. They also ensure that clients acquire vocational skills and also teach clients skills of communicating their thoughts and their feelings. They also, besides working with the clients, work with the parents in what are called parallel sessions. So they go together simultaneously. Why? Because they believe the client's problems are connected to the family system as well. So for the parents, they will look at the parenting styles they are using. They will teach them functional parenting styles to help them distinguish between trying to influence and to control. Now, when you try to control an adolescent, they rebel. So they want to teach the parents styles that will encourage influence rather than control. They will also develop a positive and developmentally appropriate influence of their children, because they will begin to understand that now the adolescent requires some space, some decision making, some bit of freedom, so that they distinguish that from when they were younger. In terms of effectiveness, it has proved very effective with clients that use cannabis and alcohol, as well as other substance-related problems. Now, finally, we have the brief strategic family therapy. Like I said, it's anchored on the strategic family therapy model. Strategic family therapy model argues that family problems are as a result of the strategies of how the family interacts. So the word strategy here just means the family interactions. So if the family interacts using dysfunctional strategies, there will be a problem. If you want the family to get better, teach them more functional interactions or strategies. So it's again a structured kind of therapy delivered in 12 to 16 sessions. It targets the family interactions that are sustaining, alcohol use or drug use and other co-occurring behaviors. Let me give you an example. So the husband comes home, asks the wife something. The wife responds by shouting. Then the husband decides that the way to react to that shouting is to go and use the substance. So that's an interaction that has created or sustained a negative behavior. So you want to teach this family how to exhibit different interactions that do not sustain the SUD behavior. And some of these problems that we are talking about could be, for adolescents, conduct problems at school and at home. It could be what we call oppositional behavior. It could be illegal activities. It could be where clients associate with gangs. It could be behaviors of aggression and violence, risky sexual behavior, among others. Now, some of the techniques include, of course, like I said, they are borrowed from the family systems approach, and the role of the counselor is to identify and change the patterns of interaction that are dysfunctional and that support the SUD. So if the adolescent comes home late, the parent asks them, where are you coming from? Were you using the substance again, or were you with the bad friends again? The adolescent decides to go and use the substance. What that interaction has done, it just has sustained a dangerous pattern that you want to change. So then you teach the family, or you teach the parents to adopt a different strategy of responding to the adolescents. So this approach is also very flexible and can be adapted to a range of situations, whether the family is in their home, whether the family is in a treatment center. So it can actually be adapted to fit different settings. It's a manualized approach, which is highly structured, which then means it becomes easier to use because then you will follow the manual, but specific training is required for you to implement the BSFT. In terms of effectiveness, there is lots of evidence to support that it does work. Some of it is in treating marijuana and reducing overall substance use, reducing other problems that are common in adolescents like conduct problems, and also enhancing family functioning. So this is now time for us to reflect. When we go to our journals, let us remember to record what is the most important thing that we learned today, what surprised us, and what are some of the things we would like to know more. And this can be shared a lot in our discussion group when we meet in the chat. So thank you very much. And when you go to your resource page again, you will see that there are many pages that are given for the different evidence-based practices that you can actually use. So I want to welcome you to our last day of training because that shall be tomorrow. So thank you very much. And for any questions, please post them on the chat and we can share them in the discussion group. Thank you.
Thanks, Beatrice.